All right, let's get right into it. If you're working on the front lines, we're talking the ED, the ICU, the surgical wards, you are going to come face to face with intestinal ischemia. This is one of those conditions that absolutely does not wait. And, hesitating can be, well, it can be fatal. So let's break this down so you're ready when it really, really counts. This phrase. You've heard it a million times, right? Abdominal pain out of proportion to the physical exam. They drill this into our heads for a very good reason. This isn't just some dusty old clinical pearl, folks. It's a massive flashing red light. It's a critical warning that a catastrophe could be unfolding right inside your patient. So when they're telling you they're in agony, but your exam feels kind of normal, your ischemia alarm bells better be screaming. Okay, so here's our roadmap for today. We're going to cover why this is such a deceptive killer. Then we'll dive into the anatomy of a catastrophe. We'll look at the 4 deadly pathways, figure out how to decode the clinical clues, and finally, what to do when you're racing against the clock. Let's jump in. All right, first up, a deceptive killer. And believe me, that title is not an exaggeration. To even have a chance at fighting this thing, you've got to understand exactly what you're up against. So, what are we really talking about here? At its core, intestinal ischemia is just a brutal supply and demand problem. The gut is screaming for blood, for oxygen, and it's just not getting it. And this can happen for a few reasons, right? You could have a blocked artery, a clogged up vein, or even the vessels themselves just spasming shut. The end result is always the same. If you don't fix it fast, the tissue starts to die. And this is why we're talking about this. Look at that number. Over 60%. Let that sink in. For acute mesenteric ischemia, more than half of your patients might not make it. That's a staggering statistic. It's why getting this diagnosis right and getting it fast isn't just important, it's everything. So you gotta ask, why is it so deadly? Well, a huge part of the answer is right here, in the anatomy of a catastrophe. It's all about where the blood flows, and crucially, where it doesn't. You really have to understand the plumbing to get a grip on this disease. Okay, basic plumbing 101 for the gut. You've got 3 main arteries coming off the aorta: the celiac, the superior mesenteric artery, the SMA, and the inferior mesenteric artery, or IMA. Now, the one you really need to burn into your brain is the SMA. Why? Because it supplies a huge amount of territory. We're talking basically the entire small intestine and a big piece of the colon. So you can imagine why an SMA clot is just absolutely devastating. Now, you'd think a system this critical would have some good backups, right? And it does. There are tons of collateral connections. But it's not a perfect system. It has some built-in weak points. So the question is, where are these weak spots hiding? And here they are. These are the infamous watershed areas. You've got Griffith's Point up at the splenic flexure and Studic's Point down at the rectosigmoid junction. The easiest way to think about these is to imagine 2 different water companies supplying a neighborhood. The houses right on the border at the very end of the pipes from both companies, they're the ones with the weakest water pressure. It's the exact same idea here. These points have the most tenuous blood supply. So when perfusion drops for any reason, they're the first to feel it. Okay, so now that we've got the anatomy down, let's look at how things actually go wrong. This brings us to the 4 deadly pathways. These are the main mechanisms that kick off this whole disaster. So if you look at the breakdown here, there are pretty much 4 main ways this happens. The lion's share, about half of all cases, is from an arterial embolism. That's the big one. Then you've got non-occlusive ischemia, or NOMI, followed by arterial thrombosis. And bringing up the rear, you've got venous thrombosis at about 5%. All right, let's talk about pathway 1, arterial embolism. This is your classic textbook case, right? You have a patient with a history of atrial fibrillation and bam, sudden severe abdominal pain. What happened? A clot broke loose from the heart, took a trip downstream and got stuck, usually in the SMA. It's sudden, it's catastrophic, and the clock starts ticking immediately. Now, pathway 2, arterial thrombosis, is a totally different beast. This isn't a clot that traveled from somewhere else. This is a homegrown problem. Think of a patient with bad atherosclerosis, plaque buildup in their arteries. The clot forms right there on top of that plaque. The key difference is that these patients often give you warning signs. They might tell you about intestinal angina, this crampy pain they get after they eat, which has made them afraid to eat, so they've lost weight. It's a smoldering problem that suddenly explodes. Okay, pathway 3 is a venous thrombosis. So now we're flipping the script. It's not a problem with blood getting in, it's a problem with blood getting out. It's like a clogged drain. The blood flows into the gut just fine, but it can't leave. So what happens? The bowel gets incredibly swollen and congested, just backed up with blood, and that leads to ischemia. You should definitely have this on your radar for younger patients or anyone with a known hypercoagulable state. And last but not least, we have pathway 4, non-occlusive mesenteric ischemia, or NOMI. Now this one is tricky because there's no clot to find. This is a low-flow state. Picture your sickest patient in the ICU. They're in shock, maybe on a bunch of powerful vasopressors. Their body is in survival mode, and it's making a choice. It's clamping down on the blood vessels to the gut to shunt blood to the brain and the heart. The gut is sacrificed, and it becomes ischemic without any actual blockage. So, okay, we've got these 4 distinct ways things can go terribly wrong. The big question is how on earth you spot them. That brings us to our next section, decoding the clinical clues. This is where you really have to put on your detective hat. And we're coming right back to where we started. I'm going to say this again because it's probably the most important takeaway. In early ischemia, the physical exam is a liar. It will fool you. The patient is climbing the walls in pain, but when you press on their belly, it's soft. It doesn't seem that bad. Do not be reassured by this. That mismatch, that huge gap between their pain and your exam, that is the key clue. All right, here's your next huge anchor point. If you have a patient with bad abdominal pain and their labs come back showing a metabolic acidosis that you can't otherwise explain, you have to assume it's intestinal ischemia until you prove it's not. That acidosis, that is literally the chemical scream of dying gut tissue. And that, of course, brings us to lactate. As a marker, it's pretty sensitive. We're talking around 86%. What that means is if the gut is ischemic, the lactate is probably going to be high. So it's a great tool to raise your suspicion. But, and this is a really big but, look at the specificity. It's terrible, only 44%. So many other things can cause a high lactate, right? Sepsis, for one. So here's the bottom line. A high lactate is a very helpful red flag, but it is absolutely not a slam dunk diagnosis on its own. Okay, so your suspicion is high. You've got the clues. This brings us to the final and most critical part, racing against the clock, because from this point on, every single minute counts. So what's the move? What is the one test you need to order like yesterday? It's right here, a CT angiogram, a CTA of the abdomen and pelvis. This is your gold standard. It's fast, it's accurate, it lets you see the blood vessels directly. This is the test that's going to give you the answer. Do not waste time. Get your patient to that scanner. And of course, you're not just sitting around waiting for the CTA. You are resuscitating this patient hard. You're pouring in IV fluids. You're putting down an NG tube to decompress the stomach. You're starting broad-spectrum antibiotics because that gut barrier is probably breaking down. And for most of these cases, you're starting a heparin drip for anticoagulation. And one more crucial thing, try your best to avoid vasoconstricting pressors. If they're on them, you want to wean them if you can, because they're just making the problem worse. So let's end with this question. Think about it. Given how incredibly deadly this is and how sneaky it can be at the start, in the right patient, the older person with vascular disease, the patient in AFib, that super sick patient in the ICU, is it ever wrong to suspect it? The answer has to be no. It's better to look for it and not find it 100 times, because the one time you don't look and it's there, that's the one you'll never forget.